Academic year, health law seminar of this academic year. It's unfortunate that there is indeed a somewhat overlapping event taking place at the same time. There's a discussion on Me Too in the other building, which may certainly have attracted the same crowd. But we're really happy to have the same core people attending the last seminar of this academic year. So I certainly want, for the last seminar, we did that when we opened the seminar series, but I would like to acknowledge for the last seminar on this particular topic the fact that we're welcomed actually on the sacred land on which the University of Toronto operates. Has been a site of human activity for 15,000 years. It's the territory of the Huron-Wendat and the Petun First Nations, the Seneca, the Mississaugas of the Credit River. It was the subject of the Dishwit One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and the Confederacy of the Ojibwe and allied nations who peacefully shared and cared for the resources around the Great Lakes. Many Indigenous people in the Toronto area, Suzanne Stewart, who came to speak to our class and who unfortunately isn't here yet, I hope she will still arrive, mentioned that or put the emphasis on the fact that we actually have the biggest community or the biggest population of Indigenous people living in the cities, which many people actually often forget to acknowledge or to realize. It's also a particular moment in time actually that we have this event here. I would say a time when there is a lot of trauma with respect to the Colton Bushy and Tina Fontaine trials, and then particularly again the decision not to appeal the Tina Fontaine and the Tina Fontaine murder case, which may be legally rational, but certainly for the Indigenous community is deeply traumatizing and brings up a lot of emotional moments. It's also a time when we have the National Inquiry into Missing and Murdered Indigenous Women and Girls and ongoing tribulations around that. So all of this makes for a special moment to actually discuss issues around Indigenous women and health. And I think it's maybe symbolic, hopefully symbolic for a new era in Canada, that also non-Indigenous legal scholars are interested in the issues and are interested in looking particularly at how issues affect Indigenous women. And so for that reason, with this long introduction, I want to emphasize that it's a special moment. I really appreciate that Erin Nelson is coming to talk to us today on the topic of reproductive health care for Canada's, for Indigenous women in the Canadian context. So Erin will give a presentation. If Suzanne Stewart arrives, so I'll introduce her. I hope she will still arrive. And we will then have another commentary by Justice Alison Harvison Young. So I'll introduce the three speakers. We will have a presentation, two commentaries, and then we'll open it up for questions. So Professor Erin Nelson is a professor at the Faculty of Law at the University of Alberta since 2000. She teaches tort law, healthcare ethics and the law, and law and medicine. She's a fellow of the Health Law Institute, has served as an associate in research in the faculty. Her research interests include the interface of healthcare law and ethics, women's health, issues in reproductive health, and feminist legal theory. She's published many articles and books on a wide variety of health law related topics, so she's one of the leading scholars in health law in generally in Canada, but I particularly want to mention her book, 2013, on law, policy and reproductive autonomy, which was published by Hart, and which obviously relates to some of the issues that she will be discussing today. Then we may have a presentation, a commentary by Dr. Stewart. He was a member of the Yellowknife Dene First Nation, a registered psychologist. He's the director of the Waakebiness-Bryce Institute for Indigenous Health Sciences at the Alalana School of Public Health. And she's actually, as her research focuses on, you can sit here. Her research focuses on Indigenous mental health, healing and psychology, homelessness, youth, mental health, identity, work-life development, pedagogies in higher education, Indigenous ethics and research methodologies. She's chair of the Aboriginal section of the Canadian Psychology Association and is generally committed to advancing Indigenous healing issues through the disciplines of health and psychology.
Oh, you want me to sit over there?
Yeah. And then we will have Alison Harvison Young providing a commentary.
And my entourage is out there. I want them to sit in here. Thank you.
So, Justice Harvison Young is judge of the Superior Court of Justice of Ontario. Prior to her appointment as a judge, she was a legal academic in family law. She was appointed as a judge in 2004. Previously to her judicial appointment, she was the Dean of the Faculty of Law of Queen's University in Kingston, Ontario. She taught at the Faculty of Law of McGill University and the University of Pennsylvania Law School. Some of her many contributions to legal scholarship as an academic were in relation to reproductive rights. So she contributed, among other things, with papers for the Royal Commission on Reproductive Technologies. And she's now a judge in residence here at the University of Toronto, working on access to justice issues. So, without further ado, I will let Erin start, and then we'll have a commentary by Susan, and Alison will provide a commentary after that. And then we'll open it up for questions. Last thing, I will distribute a presence list, so if you could fill that out. We like to have a sense of who is attending the seminars, and it gives us a sense of who we reach. Thank you.
Thanks very much, Trudeau, for that kind introduction and for the invitation to come here and speak to all of you about a topic that I find fascinating and distressing at the same time. I want to note at the outset a couple of things. First, that it's a happy coincidence. When we planned today's talk, I don't think either of us appreciated that it was International Women's Day. So it's a happy coincidence to be speaking about these issues today. And the second thing I want to say is that my background and my research focus has been in health law. And so I come at this from a perspective that is sort of based in health law. And I just want to note at the outset that I want to be, I'm hopefully going to use my language and my words carefully. But if I do slip up and say things that suggest citizenship or roles in society for Indigenous people that they don't agree with, please accept my apologies. And I'm not attempting to comment on that aspect of the issue at all. I just am kind of trying to make sure that I continue to refer to the fact that we're dealing with the Canadian context. And my own background suggests to me that I probably will end up saying things that maybe I don't intend or appreciate the intent of. So what I want to talk about is access to sexual and reproductive health care in Canada for women generally, but focusing in particular on the experiences as I understand them and the concerns that have been raised about access for Indigenous women. And so I want to start with an introduction talking a bit about the healthcare system and what the system in Canada addresses and what it doesn't address. And then I will turn to discuss in general terms access to healthcare for Canadians of Indigenous heritage and background, and then talk about specifically access to sexual and reproductive healthcare. So I find these word clouds, hopefully this shows up, oh yeah, it is. I find these word clouds to be a really interesting exercise. I don't know if any of you have ever done them, but there's this online platform called Wordle, and you just paste text into it, and you end up with, sometimes a very interesting perspective on what you thought you were saying, what your text actually conveys. And I just think it's interesting to kind of consider the interlinked nature of all of these various considerations. Canadian government, healthcare, the status of women, health status, a lot of kind of interconnected ideas. And so I like to show this to kind of convey that complexity and intertwined nature of many of these issues. So, as I said, I want to talk briefly about the Canadian healthcare system. I will try to keep it brief. This is an area that it's not that easy to kind of boil down into basic principles, but maybe we can get into a bit more detail in the question period afterward. So Canada is a country that prides itself on having a universal, publicly funded healthcare system. Care in this system is made available on the basis of need, not on the basis of ability to pay. And that's a source of a national pride for many Canadians and for Canada's government. There are some important contextual factors to keep in mind in relation to the system, and I apologize if this is old territory for some of you, but I know that not everybody really has a deep understanding of these issues. So jurisdiction over health is not explicitly allocated in our Constitution to one level of government or another. It's not explicitly allocated at all, and typically the view is that the provinces have primary responsibility for healthcare, and that's how our system has actually evolved. But it's not that clear that it is only a provincial responsibility. So that's the general view. And what that means is that, in Canada we refer to Medicare and the Canadian healthcare system, but what we actually have are 13 unique systems. Each province and territory has its own system that shares similar characteristics and features, but that have their own sort of different nuances. The federal government role in healthcare in Canada is largely a financial role. And that's important for a whole host of reasons, and some of those reasons are relevant to what we'll be talking about today. The system also is a product of its history. So again, I apologize for those of you who know this history well. I just want to take a little brief detour through it. The Canadian system has its roots in Saskatchewan, beginning in the 1950s, when the province of Saskatchewan instigated a system whereby the province was covering, or was prepared to cover, the costs of hospital and diagnostic services. So that's the beginning of our healthcare system. And the Canadian government looked at what Saskatchewan was doing and thought, well, that sounds like a fairly good idea, and offered to cost share with any province that would agree to create or develop the same kind of system as Saskatchewan had. And a decade later, Saskatchewan, again, being on the cutting edge of healthcare here, developed a new program to ensure physician services. And likewise, as they did with the hospital and diagnostic piece, the Canadian government offered to cost share with any province that would agree to have a universal and comprehensive healthcare system covering physician services, hospital services, and diagnostic services. The cost sharing proposed by the federal government at the outset was a 50-50 cost sharing program, and as you can imagine, in those days, in the 1960s, maybe it wasn't quite as big of a deal, but 50% of healthcare costs now certainly is a significant amount of the provincial budget. So all of the provinces were excited to participate and agreed to participate, and over the years, these kind of separate pieces of legislation they evolved into what's now our legislation that governs the healthcare system, which is the Canada Health Act, which kind of bundles everything together, and basically, in very broad brushstrokes, provides federal funding, not on a 50-50 basis anymore, but provides federal funding to provinces that have systems, provinces and territories that have systems that meet the 5 criteria outlined in the Act. And the criteria are universality, so it's available to the entire population of the province or territory, comprehensiveness, that it covers all medically necessary services, and we'll come back to that point shortly, that it is portable in that a resident of one province can move to another province and have coverage from the province they moved from while they wait to be covered in the new province. It is publicly administered, meaning that we have a single payer system, and that has become a very important feature of our healthcare system, and that it is accessible, meaning that all Canadians have basically roughly equal access to healthcare facilities. So as I said, at the outset, the cost sharing envisioned by the federal government was a 50-50 basis, and it was actually, as I understand it, initially based on provincial actual expenditures, and the federal government would pay a portion of those. And over the years, that funding formula and approach to funding changed as well, and now what we have is a bundled kind of package of funding that comes to the provinces that's called a health transfer payment. It doesn't address exactly how the provinces or what the provinces are paying for in terms of healthcare costs, and as over the years the federal contribution has become much less than this sort of idealized 50% idea. There's some dispute and uncertainty about actually how much of the provincial healthcare costs are covered by the federal government, but estimates put it anywhere between 20% and 37%. So 37% is not as far off from 50%, but 20% is a substantially lower amount. And this has, you know, as anyone who has any familiarity with Canadian politics, this is an ongoing tug of war, shall we say, where the provinces are repeatedly asking for additional funding, and the federal government is repeatedly trying to find ways not to agree to that. So that's kind of the general picture of our healthcare system. The federal government does have some specific obligations in terms of healthcare in the Constitution, and one of those is direct federal delivery of services to First Nations people and Inuit people in Canada, including primary care and emergency services, particularly on reserve lands where there isn't provincial service nearby. The federal government is also responsible for community-based health programs and also has a non-insured health benefits program which provides dental coverage, drug coverage, and some ancillary services coverage, things that are not included in Medicare, to people of First Nations and Inuit descent wherever they live in Canada. And so I want to come back to this point about what is covered by our system. Canada's system covers medically necessary services, and so just that phrase alone gives you a sense that what we are is a system that provides diagnosis and treatment of medical problems, so illness and disease. It's really focused on the provision of that type of care. It is also focused on hospital services and physician services, and that is a product of history, you know, and the evolution of the system. And so what that means is that we have some strange inconsistencies in coverage, and you know, in a modern healthcare system context, we have a lot that is left out of what is covered by our system. So just as an example of these coverage inconsistencies, if you are an inpatient in a hospital and you need prescription medication, then you don't pay for it while you're in hospital. Once you're discharged, if you need that prescription, that then becomes your responsibility because that's no longer a hospital service. It's up to you to provide it. And some provinces do have developed pharmacare programs, and it seems that maybe the federal government is contemplating, certainly they're going to look into a pharmacare program. Whether or not that translates into a real program remains to be seen. But that's sort of a broad brushstrokes outline of the system. And as I said, the system is focused on caring for people's medical needs and medical conditions. And I want to talk now a bit about social determinants of health, which are not, you know, something that our system really addresses, and that most healthcare systems actually don't address. So it's well known in less wealthy and developing parts of the world that there are significant health inequities among individuals within those regions of the world. But these inequities are maybe less well known in a very highly industrialized and well-resourced country like Canada, but they still exist, and they are an issue that I think we should be concerned about. You know, and as I said, Canada's healthcare system is a source of pride for many Canadians and for many Canadian governments, as is Canada's population health status. But if you look a little bit more deeply into the question of health status of Canadians, you'll see some troubling gaps and troubling disparities. Mostly for Canadians who are marginalized for one reason or another, either for reasons of poverty, reasons of gender, reasons of race or ethnicity. All of these factors play a role in creating and perpetuating health inequities and health disparities. And one group of Canadians who experience intersecting disadvantage as a result of some of these factors are Indigenous women in Canada. And you know, we have, as I said, a universal system that covers people on the basis of medical need, not on the basis of ability to pay. And that should suggest, theoretically, that we would see similar or, you know, relatively equivalent levels of health status and access to services. And unfortunately, that is, generally speaking, an inaccurate picture of the situation. The picture is a lot more complicated than that. Again, because we focus on medical need and the provision of medical services, we don't address many of these underlying inequities that lead to health disparities. And we know now that the health of a population depends heavily on these social determinants of health. In terms of Indigenous people in particular, there have been some categories of health determinants that have been identified. I don't know if I didn't put them on my slide. Sorry about that. So proximal determinants is one category of determinants, and these are things that tend to directly affect a person's health, like health behaviors, the environment, physical environment, their level of employment, their income level, education, food security, all of those kinds of issues. There also then are intermediate determinants of health, which include primarily systems-oriented concerns. Education systems, healthcare systems, community infrastructure, and cultural continuity is another intermediate determinant of health. And finally, the third category is called distal determinants of health. And those are issues that are, I guess, pervade the background of what it means to be an Indigenous person living in Canada, and they include colonialism, racism, social exclusion, and some of these broader, very systemic concerns. And what that suggests actually is that Indigenous status itself is a determinant of health and can itself impact the health status of an Indigenous person living in Canada. Canada ranks 4th. Again, this is a source of pride for many people in Canada on the Human Development Index, and that's a World Health Organization quality of life index that is based on factors including life expectancy, standard of living, education level, and gross domestic product in the nation. For rural Aboriginal communities, however, the ranking is 68. So it's that I think those numbers alone give you a sense of the kind of disparity that we're dealing with and that we're concerned about. And as one group of authors, Canadian authors, has noted, there are striking disparities and health inequities that persist across Canada. And they point out that the health disparities that stem from these inequities not only cut across almost every major health outcome, health determinant, and measure of access, but have also been exacerbated by institutions such as the Canadian healthcare system itself. And so I think that's something that should give us a bit of pause in terms of how well we're managing the health of Canadians in general. So I want to say a few introductory remarks about the importance of access to sexual and reproductive health for women in particular, for women's autonomy and equality, and then I'll kind of get into sort of healthcare issues more specifically. So I think that probably I'm not saying anything earth-shattering to appreciate that both women and men have sexual and reproductive healthcare needs. I don't mean to dismiss the fact that men also have these kinds of healthcare needs or require access to sexual and reproductive care services, but I do think that there are uneven implications for men and women of a lack of access to these kinds of services. And so that's what I am particularly concerned about. The implications of being unable to access reproductive and sexual health care services for women are far more intense and play a much bigger role in women's ability to chart the course of their own life and to participate fully in civic and social society. It's not the same thing if a man can't get access as if a woman can't. And women's social and political circumstances are very intimately connected to their ability to access sexual and reproductive health care services. I think this is especially true of women who are marginalized for one reason or another, who are living in circumstances that make it hard for them to get by as it is. And when women can't access these services, sometimes what that means is that they can't exert much control over their own, the course of their own life. And I think it's really important to recognize that reality in this context. And to me, as Trudeau said, I wrote a book about this, so I guess it's something that I've thought about for a pretty long time. To me, the interrelationship between a woman's autonomy and her reproductive autonomy, her equality, and her ability to access sexual and reproductive healthcare services is obviously apparent. And I think it's critically important, and it's something that has been recognized for a long time by advocacy organizations, both domestically and internationally, seeking to promote a sexual and reproductive rights agenda. So it's not, I'm not the only one who thinks that these issues are closely entangled. You know, Canadian women in general are very lucky in that they don't face access challenges on anything like the scale that many women in developing regions face. Most of the time, women can fairly readily access these kinds of services and this type of care. One problem, and I'll come back to this sort of closer to my conclusion, one concern that I think we do have to acknowledge is that we don't think that our access problems are very bad, and maybe they may well not be very bad, at least for the majority of women, but what we don't actually have is a true picture of what our access situation is. We don't have any data. Our data tracking in health generally is not really that terrific, and certainly in the area specifically of sexual and reproductive healthcare services, we don't know very much about how accessible or not some of these services are. We do know in general terms that women who live in larger urban centers and who are educated, who are relatively well off, are able to access these kinds of services without too much difficulty. But what we don't know is you know, what happens to women who are marginalized. Maybe they're living in poverty, maybe they're newcomers to Canada who don't have facility with French or English, or maybe they're Indigenous women who are facing intersecting disadvantages. How well can they, or how readily can they access sexual and reproductive healthcare services? And I don't think that we have good answers for that. And to me, I think that's the first step that has to be taken to address the problem. If we don't know the magnitude of the problem or the scale of the challenge, then we don't have any way of knowing if anything we're doing to try to improve things is actually improving anything. And so I think that is a critically important issue to keep in mind. All right, so what about access to healthcare for Indigenous people in Canada? So, as I said, there are significant disparities in health status faced by Indigenous people in Canada compared to non-Indigenous people. They have higher morbidity and mortality rates and worse healthcare access. And again, some of the data don't speak generally to Indigenous people in Canada, but there has been some study of First Nations, Métis, and Inuit people. And these studies have shown that there are significant disparities in health status and morbidity and mortality rates. And I think one thing that we have to keep in mind when we contemplate the idea of healthcare access is that, you know, physical access is one piece of the puzzle. If you don't live near a facility, or if there are no providers in your area, you know, then you can't have ready access. That's pretty clear, and I don't think that's very contentious. But one additional piece of the puzzle to keep in mind when we're talking about Indigenous people in Canada in particular is that access is not just about physically being able to go to the doctor or go to the emergency department, that there's a lot involved in how that service is actually delivered at the point of care that can frustrate access or make access very difficult for people in this context. And so, you know, the fact of bias and stereotyping and racism, these things have not gone away, and if you have tried to access care in an emergency department that has staff that ignore you or treat you without respect, you're not going to feel very welcome. You're not going to be terribly excited about going back to seek care again if you need it. And so I think that is another factor that has to be borne in mind when we think about access to healthcare. There are also a number of social realities that face Indigenous people living in Canada, and these vary significantly depending on where people live, that can affect their access to healthcare. So often reserve communities and individuals living on reserve face a lack of infrastructure and sort of basic sanitation and, you know, adequate housing, either that's not overcrowded or that's not in need of repair. Often, especially in rural and remote areas, there can be a lack of availability of healthcare providers, that there simply aren't the people to deliver the services. Lack of access to safe drinking water and food insecurity. So all of those factors can play a significant role in one's ability to access healthcare. In terms of health status, again, we see significant inequities and disparities, and they're multifactorial. And this is one of the reasons why it's hard to kind of come up with an idea, a single idea, to address the problem or to figure out how we might actually solve these concerns, because they're influenced by so many different factors. Income levels for Indigenous people in Canada are not increasing as quickly as income levels for non-Indigenous Canadians. That is also the case with university degree attainment, that it's increasing in Indigenous populations, but not as quickly as in the non-Indigenous population. And so the gap in income and the gap in education level is widening. Indigenous people in Canada have more of their healthcare needs unmet. They have a heavier burden of illness, often face younger onset of chronic illness and chronic disability. And, you know, the interesting thing, and again, the distressing thing, is that it's not hard to imagine that when someone lives in a rural or remote part of Canada, that it can be very difficult to access healthcare because the facilities might not be there or the providers might not be there. But there is a recent Canadian study that suggests that Indigenous persons living in urban settings in Canada have even more trouble accessing healthcare than those who live on a reserve or in a rural setting. And again, I think that speaks to the context and the way in which care and services are provided at the point of delivery. Urban Indigenous people suffer from higher rates of HIV and AIDS, higher rates of diabetes, higher rates of substance abuse, and off-reserve communities right now are where half of the Indigenous population lives, and these communities are the most quickly growing communities and populations.
Sorry, can I just fix that? It's actually half of First Nations people that are registered as Indians, and
that
so that misses out on the Métis and non-registered Indigenous people and Inuit people, so it's actually about 80% that live in urban centers.
Okay, thank you. Thank you for that clarification. All right, so what about access to sexual and reproductive health care in Canada? And this is, again, something that I want to emphasize at the outset, and that I hope you will bear in mind as I sort of raise these other sort of issues about access. It's really important to note that accessibility of sexual and reproductive health services has unique meaning and unique implications for Indigenous women. The experiences of many Indigenous women in Canada involve attempts at being coerced into not reproducing, so coercive attempts at contraception or sterilization, trying to prevent reproduction, and also preventing these women from being able to raise the children that they bear. So there's, as we all know, an overrepresentation of Indigenous children in all provinces and territories' child welfare systems. So it's important to keep in mind that, you know, there are sort of different pressures depending on the different women's experiences that you're considering. So I don't want to suggest that the reproductive and sexual health concerns and challenges faced by Indigenous women are the same as those faced by all Canadian women, because I think there are some pretty important differences. But there may be Indigenous women who also do feel that what the issues are for them are the same as those for non-Indigenous Canadian women. So it's important to keep that in mind. And it's also important to keep in mind that policy has to be approached in an incredibly thoughtful way because of these unique implications, because of the history, because of the concerns about how women's sexual and reproductive rights have been handled in the past. So I'll talk a bit about abortion services and their access in Canada. I don't know if I can make that a little bit bigger. Okay, so this is a map from Statistics Canada. It's a map of Canada's census metropolitan areas, which are the red areas, and then census agglomerations, which we are not too terribly concerned about. So if you look where the red is, you can see that there isn't, first of all, very much red on that map, and that there are vast expanses that don't have any, they're just vast expanses without a census agglomeration or a census metropolitan area. And geographic considerations can pose a significant barrier, in particular to accessing abortion services in Canada. So Canada is big, and most of our population is concentrated in the south part of the country. And this, again, I think this map tells that story quite clearly. And for a long time, we didn't have a lot of information about where services, abortion services were located or could be accessed. And Wendy Norman at UBC is a physician, a family physician, she's now a Canada Research Chair in Family Planning Research, and she's been doing an enormous amount of work. She's only one person, and there's a lot of work to be done, but she's making some really, really important headway in this context with her team. So she did a survey with a couple of co-authors within the last 2 or 3 years as to where abortion services are available. And the team found that there were 94 facilities offering abortion services in Canada, nearly half of which are located in Quebec. So of these 94, 46 are in Quebec. That's kind of a staggering piece of information to contemplate. British Columbia and Quebec are the only provinces that have paid some policy attention to where abortion services are located, and so they have services in both urban centers and in rural locations, but they're the only provinces who have paid any attention to that, and so most provinces don't have that same pattern. So British Columbia, so in Quebec, the 46 centers are distributed roughly equally among urban and rural locations. British Columbia has 16 centers. 8 of them are in rural centers or rural locations, and the other 8 are in urban centers. And then the remaining 32 out of the 94 facilities in Canada are distributed as follows. So partly by population. So Ontario has 16 facilities. There are 8 shared among the 3 prairie provinces, 4 in the Atlantic provinces, and another 4 in the territories. And the vast majority of abortion services in provinces other than Quebec and BC are located in urban centers, but significant numbers of people who might need these kinds of services are not living in those census metropolitan areas. So in the prairies, as an example, you can see we don't have a lot of census metropolitan areas. I'm just going to zoom a little bit closer into that. Abortion services are only available in CMAs in the prairies, and 40% of females of reproductive age, so between 15 and 44, live somewhere other than a CMA. In Ontario, more than a third of women aged 15 to 44 live outside of a CMA with a facility, and there are no abortion facilities in Ontario that are located in rural areas. And this can have, different impacts depending on how far away from a census metropolitan area you live. But as an example, in Alberta, if you live in Fort McMurray or Grand Prairie, you probably have a 4 to 4.5 hour drive each direction to Edmonton to be able to access services. I have heard colloquially, I've heard informally that there is one provider in Grand Prairie, but I don't know if that's still the case. I don't know how well known that is, even in Grand Prairie. And so these women would face significant travel distances. In Ontario, one example is Thunder Bay, which is obviously not close to Toronto. There are limited services available, surgical abortion services available at a local hospital, and apart from that, the nearest clinics are either in Winnipeg, which is 700 kilometers from Thunder Bay, or Toronto, which is 1,400 kilometers from Thunder Bay. So, women who live half an hour from Toronto or from Ottawa, where services are available, don't face an enormous challenge, but women who live in Thunder Bay and can't get access in a timely way at the local hospital might face significant access problems. As to how accessible or not abortion services are for Indigenous women in Canada, we don't really know. There isn't a lot of information to suggest whether access is more difficult, is the same level of difficulty, or less so. But there was a recent Canadian study that showed that First Nations and Métis women were almost 3 times as likely as other study participants to report having to travel more than 100 kilometers to access abortion services. So that's a significant distance, and a significant barrier to access. Again, we don't have a huge amount of information to know, again, how accessible services are. We don't know how many Canadian hospitals provide abortion services. There was a study done, and I should say study in quotation marks. There was an attempt at research done in 2006 that suggests that about 16% of Canadian hospitals provide services, but it wasn't really a rigorous study. It was kind of a secret shopper kind of study where someone phoned hospitals to ask if services were available, so we don't know if what they received by way of answers was a very true or accurate picture. not all provinces still fund clinic abortions, which are much more readily available than hospital abortions. Only 4 facilities provide abortion services for all 3 territories combined, and you know, I showed you the map. The territories are vast. That's maybe not going to create ease of access. We do have some hope on the horizon with the approval of mifepristone in Canada, which is the drug used in medication abortion. So theoretically, a person would not have to go to a facility that provides abortion services to be able to access services. It took a long time to get approved in Canada. I mean, partly it took a long time because it took a long time for a manufacturer to be willing to apply for approval. But even after the application, it took 2.5 years for approval to happen, and then another 1.5 to 2 years before the drug became actually available, even after it was approved. Contraceptive services also, you know, in general terms, I think most women who are living in an urban center and have a level of education that permits them to know where they can access services have fairly ready access. But regulatory barriers also play a role in what Canadian women are able to access. Far fewer products, variety of products, than are available in general and that are available in other countries. And one important piece of information to keep in mind is that no long-acting contraceptives are available, approved for use in Canada. I think Trudeau's about to tell me I'm running out of time. Yes? Okay. Okay. I'm going to zoom ahead a little bit and talk about a couple of other issues and then try to wrap things up. So in terms of access to prenatal care for women living on reserve, this has been described, the level of access has been described as being in a state of crisis by the Society of Obstetricians and Gynecologists of Canada. I don't know how much more bad it could get than a description like that. The other thing that goes together with that is that women living in rural and remote areas in particular often have to leave their community, sometimes for a month or longer, in order to give birth, because there are no labor and delivery services available where they live. And what this means is that women are separated from their families at a very critical time in their life. And childbirth has become a stressful life event that sort of isolates women from their community instead of bringing them together with their community. And there are significant costs to that, both financial and costs to the community. Again, here is a situation where we don't know much about numbers. We have estimates suggesting that maternal mortality, meaning women who die within pregnancy or within about 42 days after pregnancy, is probably or approximately roughly double for Indigenous compared to non-Indigenous women in Canada.
Isn't that recorded on the, is Aboriginal status not recorded on the death registry? I thought it was.
No.
It's not.
And then we also know that stillbirth and perinatal death rates are also roughly double. So we know that complications are much higher. We don't have good data. We have estimates that suggest these significant increases. All right. The one last thing I'll say about access to reproductive and sexual health care is that also in addition to these other access challenges, Indigenous women tend to have more reproductive and sexual health care needs, higher levels of needs than other groups do. Mothers tend to be younger. They often tend to have more children. Their babies often have higher birth weights that can lead to problems in labor and delivery. They have higher rates of sexually transmitted infection, which can lead to infertility. So the challenges actually encompass all of the potential life events that women face. So, as I said, we don't have reliable data, but even without that reliable data, it's very difficult to avoid the conclusion that Indigenous women in Canada confront significantly more reproductive and sexual health care concerns than their non-Indigenous counterparts. I just don't know how to reach a conclusion other than that, and that they face a marked disparity in access to needed medical care. All right, so I'm going to do a whirlwind conclusion here, and maybe talk about this in the questions. So we need better data collection. Until we know more about the actual problem, it's really hard to know how to address the problem or problems. we also need to confront the systemic issues that face our populations and our Indigenous population. That jurisdictional conflict, so disagreement between the province and the federal government and who is supposed to pay for what services, needs to be addressed and overcome. And we need to consider and think about access in rural and remote parts of Canada, and about how the service itself is being provided even when it is available. And we need to kind of talk about the importance of culturally sensitive, culturally competent, and culturally safe care for women. The other thing to think about is that, you know, many of the problems that I'm talking about arise out of a historical reality, but these are not only historical problems. And 3 years ago, we heard reports from Saskatoon about women, Indigenous women, who were either induced to have a tubal ligation or actually coerced, or who had tubal ligation without their knowledge while they were in hospital for labor and delivery services. So this is not gone. This problem is not gone. And again, that suggests that we need to focus on the provision of culturally safe care. We can't fix these problems without a cooperative and concerted effort by all levels of government, Indigenous governments included, and Indigenous communities and healthcare providers. And I think in addition to the recognition of the need to provide culturally safe healthcare, we need to start thinking about developing culturally safe or culturally competent policy that actually addresses what the problems are and where they have come from, and allows those problems to be addressed in a manner that is meaningful and helpful to the people who are experiencing the challenges. Okay. Stop.
Okay, very good. So do you want to comment first? Or you want to go after it?
I can comment first. I mean, I feel like there's so much information that was presented by Dr. Nelson, and thank you for bringing together such a succinct presentation of a rather large issue and trying to educate everyone on the context and the history of colonialism at the same time. What I heard that was really important as a health researcher and a clinician is that what was reflected in Dr. Nelson's work is further reinforcing the overarching understanding that the two major issues regarding Indigenous health in Canada are around access and racism. And I would say those issues are intensified for Indigenous women on these issues because of the double jeopardy. And I was a little late, my apologies, because I was giving a talk this morning at Women's College Hospital for International Women's Day, which is where my youngest daughter, Danae, was born by an Indigenous midwife, who's sitting right over there. And it feels like the convergence of that understanding that Indigenous people's health is different, not because they're biologically from a different race, but because of the systemic policies that have been used to personally harm a group of people based on their race and gender. And those, I think, are the issues that our colleague here is trying to highlight, is how that harm that has been perpetuated through the legal system has become very personal and has really affected the lives of individual people and families like myself, like my daughter, and like all of you, because the fact is that all these laws and policies that have created this situation for Indigenous sexual and reproductive health affect everyone in Canada, because these laws have created the situation where you're either negatively impacted and harmed by these policies, or you're directly benefiting from them. Everyone in this room falls into one of those two categories, and how we behave and act as a result of being in one of those two categories determines the future of what will happen next. Is that a good comment?
Yes.
Okay. Very good. So there will be questions and more time to intervene. Alison?
So I listened with great interest to Erin's presentation, and the first thing I have to say, well, I have to say two things. First of all, I've been out of the loop, as it were, of the academic issues relating to reproductive health really since my appointment to the bench some 13 years ago. And it's a real pleasure to be back, able to think about it. Second, judges, of course, are not supposed to have views on these issues. And so I'm taking a certain amount of license in my extrajudicial capacity as a visitor in this faculty to play a role that I probably wouldn't normally play. But I'll just make a few comments on the things that really struck me with this paper. The last thing I would say is that preliminary comment is that my project during my study leave here relates to access to justice issues, which of course are quite parallel to a lot of the issues that Erin has raised, particularly with respect to what meaningful access is for Indigenous peoples and other marginalized groups in society as well. But my first, more substantively, my first reaction when I read the paper was how little has changed since the Morgentaler decision in 1988. The Morgentaler, before the ink was dry on Morgentaler, which of course ended the criminalization of abortion in this country, the focus shifted to understanding that there were going to be issues relating to access. There was at the same time a great deal of optimism that those were kind of minor mechanical things that could be dealt with. Well, of course, here we are 30 years later, and as we hear from Erin, and as I think most of us already know, for marginalized populations across the country, meaningful access, has not moved along very much. As I will come back to in a second, I think the focus has shifted now to meaningful, equitable access. The second impression from Erin's paper that she sort of ended with is the desperate need that we have in this country for good data. I think that this is something which Canada, for reasons that I don't really understand, is very poor on compared to other industrialized countries. And it's not just in this area, in the area of healthcare. In fact, I think in some areas, healthcare is better than other sectors, but we just do not have or collect good data. And I'm again referring to the justice system. When you start looking at reforms, one of the obvious things you want to know is, well, what have been the results from the last set of reforms? And it's very hard to get any kind of meaningful data. And that's something that I would hope changes. The other reality, of course, that is not going to change, that continues to be a challenge in this area, as in many others, is the division of powers in this country, particularly federal and provincial division of powers. The problem with that, of course, has been that it has facilitated a lot of finger pointing. Each level of government is able to say, well, what can I do? Really, it's up to the feds to do that. Or the feds say, well, really, it's up to the province to do that, and or consider that or address that issue, and that has enabled a certain amount of inertia for a long time. As Erin said, this is can be profoundly depressing, but I do think that there is some hope on the horizon because of a convergence of energies, I guess is the best way of expressing it. One of those comes from what has been happening in the area of end-of-life and medically assisted dying. And there's a recent decision of the Divisional Court in Ontario called the Christian Medical and Dental Society of Canada versus the College of Physicians and Surgeons of Ontario that is in one sense, it's not terribly relevant because it's almost certainly going to go all the way to the Supreme Court of Canada, and this is just at the first stop. But in this case, the college had passed 2 policies. One applied to doctors unwilling to provide, quote, certain elements of care for reasons of conscience or religion, generally understood to target abortion services. And the policy provided that if they weren't willing to provide those services, they have to make an effective referral to another physician. And that means good faith to a non-objecting, available, and accessible physician, and the referral has to be made in a timely way. There was also a similar policy, the second policy they dubbed the MAID policy, with respect to medical assistance in dying, same obligation. The applicant doctors challenged the constitutionality of these policies on the basis that they violated their freedom of religion, mainly. The divisional court upheld the policies and the constitutionality of these policies, and in the course of their discussion of Section 1, it talked about the validity of the objective of protecting the public, preventing harm to patients, and the facilitation of access to care for patients in our multicultural and multi-faith society, and talked about the essential purpose of these policies being the facilitation of equitable access. And my point is that there seems to be much more political will and momentum these days around medically assisted dying than there has been with respect to reproductive autonomy. Some might suspect that the fact that the reproductive autonomy affects women more than men may have something to do with this. But the point I'm making is that I think perhaps the climate is right, and there's a potential for the access to reproductive services can kind of piggyback and help use some of the momentum that is out there on these other areas to move forward. This is also a period, and I've been struck by this while I've been here at the university, it's a period of great increased awareness of the challenges facing Aboriginal and Indigenous peoples in Canada, and, well, around the world, but in Canada in particular, and of the need for us all to contribute to a better world for Indigenous peoples in this country. And I think that those things may be converging so that access and meaningful, equitable access can now become more of a reality for all Canadians and for Indigenous women. And those are my comments. Thank you.
Okay. Very good. On that note, we'll open it up for questions. I have first 2 students. Jennifer. Okay. Mm-hmm.
I know I'm going to pronounce the name of the drug wrong, but my question was regarding, you think,
Waakebiness-Bryce, or I don't know how you say it. I know.
Okay. So you mentioned in your paper the high cost and how it doesn't bode well for access to abortion for Canadian women. So I wanted to clarify, does Medicare cover that because it's administered by physicians? And if that's the case, if the law changed to permit non-physicians to prescribe it, then would that bring it up to 5%?
So it's not covered by Medicare in general, except that many provinces have agreed to cover the cost of it. Not all provinces have agreed to cover the cost of it, but it wouldn't be something, it wouldn't be an ordinary or typical thing that's included because it would be an outpatient prescription. You're very perceptive though to raise the issue of what happens then if prescription authority gets broadened, and this is something that Wendy Norman, that doctor I referred to earlier, has been working on. She's seeking to have the scope of practice of midwives, for example, increased so that they would be able to provide and prescribe this drug, and also nurse practitioners, I think, are in the offing, potentially as being allowed to prescribe it. And that, if it were a typical Medicare service, that would potentially take it out of the scope of what's covered. But it is being covered as kind of a, I don't know, extraordinary expense, or I don't know how they're exactly framing it, by some provinces.
But not all provinces would do it.
Not all provinces, no.
Does Ontario do it, just out of curiosity?
I think Ontario does.
Yes, Ontario does it as a provider that is able to prescribe misoprostol for not abortion services, but for postnatal pregnancy. But it's actually a really stable drug that's very easily transportable, and it's like in a pill form, so it's something that could be used very easily across anywhere in Canada. And midwives have been having increased access for some purposes, so it's being looked at to expand the scope for midwives, which would increase access for people to those services.
Any other comments from our two commentators? No? Jacob?
Yeah, my question's actually different than what I sent you, Professor. And thank you very much all for being here, and also to Danae for being here as well. My question's for Justice Harvison Young. Thus far, Section 7 of the Charter has not allowed for a positive rights interpretation, but the majority in the Goslin case suggests that there might be some special circumstances under which one could make a successful Section 7 claim. Do you think, given the special position that Indigenous communities occupy in Canada, that access to reproductive services could plausibly form the basis of a positive rights interpretation of Section 7?
That is a really tough question, and I don't have a crystal ball. I think, I would say we're closer to that now with some of the decisions that have been made than I would have said we were 15 or 20 years ago, and I see Erin nodding her head. I think with the emphasis on equitable access, I don't think it's a huge leap to find a positive right in a situation where there's any argument that such rights are available elsewhere or in other parts of the country. But of course that starts to look like a Section 15 right rather than a Section 7 right. So it's much easier if you're talking about deprivation of a right. But I think we may be getting there in some respects. But that's about as much as I could say. I think this decision will be interesting to see when it goes further up. The Christian Doctors case to which I referred, I think it would be particularly interesting in the Supreme Court to see what they have to say, because it could well be something that could form the basis for positive rights in the future.
Oh,
Okay, I'm an economist, so I'm going to approach it slightly different. First off, a comment on the data. One problem that we have with Aboriginal data is in many cases the Aboriginals have refused to fill out surveys. So for example, I have decent survey data from the last census up north of 50, but Six Nations refused to fill out the census. So that makes it very difficult to do comparative analysis, because everything we do in government funding is relative, because we are allocating on the basis of equitable need. So I'm working on projects now to discuss equitable need to child welfare and to family services. And one of the characteristics of that, and this is where my question comes, and it really gets down to a legal, I'm going to frame it in a legal question, because if you take a look at the distribution of population, what you see is, for example, for Nan, the Nishna, whatever, up out of Thunder Bay. Thunder Bay is a big city, and they've got 49 communities that range down to something like about 56 people, okay, that are geographically quite difficult to access. We now have some standardized measures of access, and we actually have some standardized measures of service that StatCan's been working on, and I'm actually going home to do some mapping to play around with when I get back to the whole. But the point is what is the right to access in a physical sense? And I'm asking you people as lawyers what you can expect. I was very excited to see that there may be medical solutions in terms of drugs and stuff, because that becomes a much more effective and thing. But when you can't even get to a doctor to get prescribed, and when doctors want to see you to get paid, okay? And they are a long way away, because as I said, I'm working on, I'm writing right now on the remoteness concept and all sorts of blah, blah about that. So I'm asking the legal question, how do you define a right in terms that is to any service that is spatially delivered in the context of Canada? One characteristic of other countries is they have enormous density of population, a much different geographic density. If you look at the maps I'm playing with in the north, it's, you know, you get the point. I'm spending all my time on that. So that's the question.
Well, I don't know that I have an answer for that. I mean,
But you would understand that it's a legitimate question.
It is a legitimate question. I just think that we haven't turned our attention and creativity sufficiently to how we might address it, and I think, you know, maybe what will be very interesting is if improved access to abortion services because of mifepristone, being able to be more widely available and widely prescribed, if that maybe makes people look at some other access problems a little bit differently. Some of the access problems are, you know, they range in the cause, right? So the reason why women have to leave their home to give birth is because in the 1970s, the decision was made that it was better, all things considered, to have, especially a first birth, but to give birth in a hospital where you could access high-tech facilities. And I think that thinking has really started to shift. And the recognition that you have to balance benefits and disadvantages, and from the standpoint of what benefits a woman and the child and her family within the community, maybe access to a hospital isn't as important as we might thought.
My guess, looking at, you know, technologies have changed in terms of, like, obviously, not being a male, I'm not even going to comment about birth, but the obvious problem is that you need some facilities which can be flown in and the rest of it. The other characteristic, though, is the federal government and your tax dollars are paid for extraordinary amounts of money, so that in a lot of communities they have far better internet access than I do. Okay, quite seriously, paid for at extraordinary cost. So the things that we could do for remotely are at least I would say that is a help. I can't even comment whether that's useful for sexual and reproductive health.
Well,
I think the issue is that there are probably technologies and technical solutions that are feasible if you're prepared to spend the money. And the last simple comment is that the biggest problem is when you talk about jurisdictions, the fighting between when something is partially funded by the feds, partially funded by the provinces, or not even funded, that creates a problem. And until we solve that, and that may be a legal problem and a constitutional problem, okay? I think that's going to come up in pharmacare. I was having a debate with friends at the Department of Finance last week about that. And I think those are where you're going to have to do.
Can I just follow up on that? I think these are more political problems than they are legal problems. I think that you mentioned the issue about the distance to a doctor and, you know, physical distance to a doctor, for example. I think there is change. There are people who know a lot more than I do about, you know, the increasing roles that nurse practitioners, midwives, other people in communities are playing in various aspects of healthcare, but also technology, Skype, and so on, is putting pressure on some of the sort of absolute necessity that a doctor cannot bill unless you're right physically there. And so I think there are solutions there, and they may be pressured partly because people are increasingly ordering drugs online, not necessarily legally, which of course has health risks, but that puts pressure on the legal regime. So all this to say is that I think some of the potential solutions are coming from other social developments that may be hopefully used to generate some change.
Any other questions?
If I could just speak for a moment to the concern about data regarding Indigenous people. You brought that up a few times, and our colleague over there brought that up, and he brought up a point that Indigenous communities refuse to fill out census data.
Not all of them.
Well, you cited Six Nations.
Six Nations specifically.
So
which is-
what might be some of the reasons that Indigenous people may not want to fill out government documents? Does anyone here have any ideas about that? Not you, Juan. Juan works in my office.
I've only heard just another way of
Stigmatizing, that's true. What else?
Fear of being identified, to have their children taken or things.
Absolutely. Every time there's a knock at the door, I still think that someone's showing up to take away my status Indian children. There's a lot of policies that have been used, that have been based on data that's been collected on Indigenous people that have been used to harm them. So there's a lot of reasons. So really the onus is on the government and the systems in society to change their relationship with Indigenous people in order to make Indigenous people feel safe in those culturally safe ways that you talked about, to participate in our healthcare systems, in our data collection systems, in all of our systems. And that's going to take a lot of what the government is calling reconciliation, which is really just a crock anyways, but that's a different topic.
If I
Sarah?
could just add on to that, I think that one of the things that you spoke to is the urban myth that health outcomes don't actually improve when we move into urban centers. And I just participated in a study in Toronto recently where we were able to demonstrate that the health outcomes are definitely not better for Indigenous people, and particularly the sexual and reproductive health outcomes for Indigenous people in Toronto. And the population size in Toronto is at least 75,000 Indigenous people living in just in the city of Toronto properly, which is the size of the whole Sioux Lookout region, including all of the First Nations. And so if 80% of the population are living in non-reserved communities and non-isolated communities, but actually living in urban regional centers, and our health outcomes are not improving, it's not purely a geographic issue. It's actually much, much bigger, and it's much, much more related to the systemic issues and the racism and discrimination, and those are the things that we need to fix, not the geography.
Thank you. I just want to ask the perspective, legal perspective of this issue is, so how we are going to balance the self-determination right of Indigenous communities, of Indigenous peoples in the world versus the right to intervene or the right to protect or the right to act in a situation. For example, knowing that sterilization of women in Indigenous community was a colonial tool that was used to stop the growing of Indigenous community in between 70s and 74, more like a 450 cases were documented. And in a way that the structural system that we are just promoting in our societies put in a very, very difficult position a young Indigenous woman who is pregnant, because the future of the future baby is going to be very difficult in terms of constraints, of economic constraints, social, political, education. So how we are going to manage that, and how from the perspective of law we are going to balance these two rights, perhaps the obligations and the obligation that the federal government and provincial governments have just to protect these type of rights.
Well, I think as Alison said, the problems are more political than they are legal problems, but that doesn't mean that they sometimes don't manifest as legal problems. I think it will be, I don't have a crystal ball either, and I think it will be very interesting to see what happens when a rights contest like that develops and is actually faced, by the courts, because I don't know what to anticipate. The closest example that comes to mind of what you're talking about reminds me of the DH and Hamilton Health Sciences case that happened. Every year that I get older, I forget how many years ago things were, but a few years ago, recently, where there was this decision that the mother's Aboriginal rights were such that she was entitled to pursue traditional medical, Indigenous medical approaches for her daughter, and could take her out of chemotherapy. And the sort of significant concern raised after that decision was made was that leaves children who are Indigenous unprotected if their parents are making a decision that puts them in harm's way and isn't in keeping with their best interests. And I think what happened after that case was a negotiation process whereby the parties came to a negotiated agreement, and everybody was able to kind of participate and agree that both traditional Western medicine and traditional Indigenous kind of medical approaches could be used at the same time. And I think that's maybe an example of how to approach this problem from a cultural safety standpoint. I also think the issues arise less when there is cultural sensitivity and cultural safety in place. I don't think, it's my understanding that the DH case in many ways came about because there was a comment by a member of the nursing staff that was perceived as racist and harmful to the family. I think that's why the family became afraid of keeping their child in medical care. And if we can alleviate those kinds of systemic concerns, the rights contests won't materialize to the same degree.
We have to stop. Please join me in thanking the speakers. We're nearly over time, but there is one more question that you can ask in person of the speakers.
Thank you. I'm sorry.
So thank you very much.
Nice to meet you.
Really nice to meet you.
It's nice to meet you.